Why don't we get started? These are the oral presentations for clinical operations. So just make sure that you are in the right group. So we should have 7 presentations in here. So for the sake of time, just so when everyone knows, this is a oral presentation. So these are going to go 10 minutes. So I keep pretty firm, just so you know. I'll throw in the chat if you have a minute left, and but I will cut you off, and don't take it personally, just so we can give everyone the sake of time. And there will be 2 minutes for QA for all of your presentations. So yeah, I've read all the abstracts. This is a really great slate. So anyone who's interested in clinical ops should actually get a lot out of this. So why don't we get started first? So the first presentation is going to be by Dr. Afterback, but it is going to be presented by Jason Brenner. It just so happened, and we really did not pre-plan this, but the 2 vice chairs of my department actually have presentations in this block. So one of them is Will Afterback. The other one is Greg Guerra, who has the 3rd presentation. So I'm going to be completely neutral and not be snarky. I promise them that. So, but you guys can do whatever you want to them. I mean, it's all hands on deck. So Jason Brenner will be presenting. Just for reference, Jason Brenner is a college student. I just graduated, right, from University of Michigan. So you're allowed to take it easy on him. But his mother is a dean at a medical school, so you can, gauge your darts in the way that you want. So, okay, so why don't we get started? Jason, do you have co-host privileges?
Yes, I do.
All right, so you can start sharing and
the screen.
You can go.
You see the screen? Yep. Can you hear me? Okay. Dr. Gupta, thank you for that introduction. I'm Jason Brenner, and today I will be presenting the abstract, a retrospective evaluation of the resiliency of stroke protocols at an academic tertiary hospital during the pre-pandemic, pandemic, and recovery period. The authors for this abstract were Dr. William Afterback, Dr. Greg Guerra, and Dr. Sanjay Gupta, and we have no conflicts of interest to report at this time. So in cases of stroke, time is essential. So expeditious evaluation, transportation, and treatment decision-making is crucial to reducing a patient's door to physician and door to CT times and ultimately outcome. So as is the case with many aspects of emergency department care, the COVID-19 pandemic might have impacted treatment times for stroke. Changes in ED volume and additional precautions might have caused delays in stroke protocol execution, and alternatively, reduced volumes might have resulted in more speedy execution of stroke protocol. So for this abstract, the goal was to examine the impact of COVID-19 and the time of day, meaning day or night, on the door to physician and door to CT times for patients triaged along a stroke protocol pathway. So for our methods, we conducted a retrospective analysis of data collected before, during, and after the pandemic. So from January 1st, 2020 through November 30th, 2020. And the single site that we analyzed data for, it's a suburban tertiary academic comprehensive stroke center with an annual volume of 80,000 patients. So we defined the pre-COVID timeframe as January 1st of last year through February 29th. The COVID time period began on March 1st and ran through May 27th. And then the post-COVID period started on May 28th, and the last patient for whom we collected data was on November 30th. In terms of the time of day, we defined the day period from 7 a.m. through 6:59 p.m. and night from 7 p.m. through 6:59 a.m. And we conducted a 2-way MANOVA with 2 independent variables, COVID period and time of day, and 2 dependent variables, door to physician and door to CT times. So on the screen, you can just take a look at the sample size of our study, the overall sample sizes, as well as the smaller group sample sizes. And so the results of the MANOVA did not reveal any significant results. The interaction between COVID period and time of day was not statistically significant. The p-value was 0.778, as you can see. The two main effects, so the first for COVID period was not statistically significant, and the second for time of day was also not statistically significant. And the p-values are rather high, suggesting that power was not really a factor, just not a significant relationship there. So prior to the study, we hypothesized that there would be a statistically significant pattern. In fact, we did not discern any statistically significant effects for COVID time period and or time of day for door to physician or door to CT time. So essentially, stroke treatment time was not significantly impacted by the pandemic timeline nor period of the day in the site examined. And we believe that this supports reliance on certain protocolized treatment pathways to ensure quality outcomes regardless of volume or utilization. So in future studies, we'll analyze data from additional sites as the COVID experience varied. We'll look at potentially smaller tertiary sites or urban sites, and then also might be useful to look at whether sepsis protocols had similarly unaffected patterns. Thank you, and I'll take any questions.
All right, we have a few minutes for questions if anyone has questions for Jason, but you could actually throw out hard questions because Will Afterback is here and he was the author of the abstract. All right, well, so I mean, this was, you know, obviously our department. So we were in somewhat of the original New York City area COVID hotspot with this, you know. So what came into play a lot was obviously, you know, safety and body substance isolation and an increased, you know, kind of sanitary, you know, needs for the department for CTs and things like that during that time. But Jason and Will, so why do you think we didn't see improvements of times during the COVID period? I guess especially at night when volumes were down. Should our times have been faster, I guess, with a decreased volume?
Yeah, it's a good question. It's possible that should have been the case, but really, it kind of just shows strict adherence to the protocols. You know, these are rigid protocols that were just followed, obviously, before, during, and after. So we didn't see any, but I guess there could have been.
Yeah, I agree. You know, I sort of went into it with the expectation that you should see, with decreased volume, arguably you should see better times. And I think it's essentially the fact that we had such small differences in data set during the periods, and especially as displayed day and night, you know, without accounting for COVID period, that once you have a process enacted that is predictable, reliable, and repeatable, really, no matter what's going on externally, won't actually affect the validity of that process. And I think ultimately that's what we're putting forward, is that for certain diagnoses, especially time-dependent ones, having these kinds of rigid, you know, as much of us may get frustrated with some of these timelines, but having them sort of instituted really does help decrease variation in care that patients may experience.
All right. Thank you. All right. Thank you for that presentation. And we are going to keep moving right along. So our next speaker will be Dr. Maureen Canales, speaking about operations factors associated with ED length of stay, analysis of a National Emergency Department operations database. Let me see if I can make you a co-host.
Let me see. Not yet. Oh, now I can screen share.
Okay, wonderful.
And y'all can see that.
Yes. So you have 10 minutes starting now.
Great. Yeah, sorry I wasn't here on time. My internet at home decided to cut out, but luckily I live close enough to the hospital. All right, so hi, my name is Maureen Knaus, and I'm a second-year administration fellow of EM Administration and Leadership at UMass through the Richard B. Agababian Fellowship. Today, I'm going to share with you some insights from our recent research on operational factors associated with ED length of stay. We have no disclosures. Our study approach is simply described here. The ED literature strongly correlates deleterious effects in patient care and satisfaction with prolonged ED length of stay. However, the current literature identifying those factors does have some significant limitations in terms of study size and lack of addressing some confounding factors within those studies. So our team asked ourselves, can we further identify and quantify factors that contribute to ED length of stay and simultaneously address some of the prior methodological limitations? So we moved forward with a multivariate regression analysis of a large national ED operations database. That was with the goal to further inform efforts to improve patient flow through a more robust and generalizable understanding of length of stay factors. So next we will review our methods. First, we explored our database of the 2018 ED Benchmarking Alliance survey results. This survey collects annualized data from over 1,300 EDs nationwide, and we focused our analysis on adult-only or adult-peds mixed EDs through removing all freestanding, pediatric, and specialty EDs, which resulted in about 1,052 sites included in our analysis. Next, a panel of ED operations experts identified 18 of the 30 survey variables with face validity for potential predictors of ED length of stay. Then we cleaned the data by removing 2 variables that had over 40% non-response rate, which is a common rule of thumb for imputation. Any remaining missing variables were imputed using a non-parametric imputation algorithm. On final review, the variables did not have significant multicollinearity. So now that we had a fully complete database, we created 2 linear regression models, one for admit length of stay and one for discharge length of stay, using 80% of our database and recorded the model's goodness of fit, or R-squared value. The finalized variables included extrinsic ED factors like academic, trauma level, median boarding, intrinsic ED factors like intake APP, intake physician, fast track, and population factors like patient volume and pediatric volume. Once these models were created, we used them to predict ED length of stay from the remaining 20% of ED sites that weren't included in the model creation and recorded the goodness of fit, now called out of sample R-squared. This step allowed our team to ensure the models weren't overfitting the database and thus could be generalizable to EDs outside of the database. So before we move on to the demographics of the finalized database, I want to take a moment to highlight some of the limitations of this methodology. First, there are the expected standard issues of survey-related research. Next, the expert panel may have excluded variables that actually did have an association with length of stay. Next, while the variables did not have linear correlation with each other, some variables may have significant non-linear correlations that we missed. And lastly, the imputation algorithm that we used assumes pairwise independence, which may be incorrect if linked ED sites are listed as separate sites in the survey. So before we get into the results of our models, I'll quickly share the demographics of our finalized database of the 1,052 included EDs. As you can see, the majority of EDs included were non-academic. Just over half of them had no trauma level distinction. Most have an annual volume of under 60,000, with the largest cohort reporting 20 to 40,000 annual visits. And most reported themselves as being located in a suburban community. So now let's review our model outputs. It's a big table, we're going to go through it. So the first column of this table lists the 16 variables included in the analysis. The next 2 columns list the coefficients for each variable for each linear regression, admit length of stay in the middle and discharge length of stay on the right. The values in bold showed statistical significance. To further orient you, the first row of this table would read that an academic ED would have an admit length of stay of almost 26 minutes longer and a discharge length of stay of about 9 minutes longer than a non-academic ED. The sixth row of the table, the fast track, would read that an ED with a fast track would have an admit length of stay of about 19 minutes less and a discharge length of stay of 8 minutes less than an ED without a fast track. So overall, the admit length of stay linear regression model returned an R-squared value of 63% and was applied to the new data, returning an out-of-sample R-squared value of 54%. The discharge length of stay linear regression had an R-squared value of 56% and an out-of-sample R-squared value of 59%. So for those unfamiliar with predictive modeling, there are no clear standard on good versus bad R-squared and out-of-sample R-squared values. But there is like a general rule of thumb or agreement that over 50% is acceptable in scientific studies, and this model would constitute a moderate finding. So in the table, we saw that the statistically significant variables for admit and discharge length of stay are similar with some key differences. Those significant in the admit length of stay model really reaffirmed what we knew from previous literature. So I'm going to focus our discussion on discharge length of stay findings that were not previously discussed in the literature. So first, we see that high CPT is associated with an increase in discharge length of stay. High CPT percentage, while influenced by billing and coding practices, may indicate a higher level of acuity of patients who require more resources and thus a higher length of stay. On the other hand, higher pediatric percentage of patients is associated with a decrease in discharge length of stay. And this makes sense, as prior literature has really reported that pediatric patients have typically lower acuity and complexity than that of their adult counterparts. But it's really unclear why these two variables are statistically significant in the discharge length of stay model and not the admit length of stay model. Next, the models predicted that discharge length of stay increases as X-ray and CT utilization increases across the ED. However, this variable was not statistically significant in the admit length of stay model. We hypothesize that there are two explanations. One, for admitted patients, the additional time for imaging did not affect their overall length of stay because the time waiting for imaging ran in parallel with other factors influencing their length of stay, and therefore the imaging contributions were masked. Or the second hypothesis is that other factors like boarding became so dominant for admitted patients that imaging no longer was significant within the multivariable analysis. And next, the models predicted that EDs with intake doctors have a higher average discharge length of stay of just over 16 minutes compared to EDs without intake doctors. And obviously this seems counterintuitive, but we have to remember that a limitation of these models is that they are limited to correlation rather than causation. So we hypothesize that an intake doctor does not cause discharge length of stay to increase. Instead, we hypothesize that EDs who have prolonged discharge length of stay issues tend to institute intake doctors to try and improve their length of stay metrics. And lastly, the models predicted that discharge length of stay increases as median boarding increases. Every 1 minute of median boarding is predicted to increase average discharge length of stay by 0.18 minutes. This is a really important finding, as ED operations leaders anecdotally have reported that they are being held accountable for loss of length of stay of discharged patients rather than admitted patients, under the premise that the discharged patient experience is entirely under their operational control. Our findings refute this notion, as boarding, among other previously discussed non-intrinsic ED factors, are associated with prolonged length of stay for discharged patients. So in conclusion, our models have been able to support previously identified factors of ED length of stay in the literature, as well as add new variables to literature. So in addition, we were able to differentiate factors that have more significant association with admit length of stay compared to discharge length of stay. This final slide really summarizes the previous factors associated with ED length of stay in the literature. The bolded and black factors are those that were previously noted in the literature and that our models support. The bolded and blue factors are additions to the literature from this research study alone. And you will note that we placed imaging and utilization in both population and intrinsic factors on the right, because resource utilization can be influenced by both the patient population and local ED practices. And with that slide, I will close. Thank you all for listening, and I'm happy to take any questions.
Wonderful. Does anyone have any excellent presentation? Does anyone have any questions for Dr. Canales?
Hi, Dr. Canales. Greg Guerra. Excellent study. I just have a couple of questions. I think you mentioned in the beginning there was no collinearity that you found amongst the variables.
Yeah.
Okay. I'm actually somewhat surprised because I would have expected there to be some collinearity with CT use and CPT codes, but I mean, the study is what it is. And then you had mentioned that I found the other thing I found interesting was that CT use per 100 or every 100 CTs used actually had a negative association with boarding length of stay.
Yeah.
And you had said that there was other factors that run parallel to that. So what were the other factors that you thought might contribute to that?
Yeah, so first for the multicollinearity, we use something called the variance inflation factor. So that does have its own limitations because it only does linear. So I agree, there certainly could be some collinearity that we missed by using just the VIF instead of another type of looking at collinearity factor. But other things that could run in parallel, it's more that, so like there are things that we can't do. So like consultants, those are other things that could run in parallel that maybe the CTs, I've admitted patients without the final read or without the CT coming back, or that perhaps their CT isn't the reason that I'm admitting them. So those could be things that are running in parallel at the same time. But it did seem that the admit length of stay coefficients on this, if you look, are much larger. Like each coefficient is a much larger coefficient than the ones on the right. Like alone transfer out attributed to a huge amount of the minutes of this linear regression. So my thought process is that perhaps transfer out was pulling, I mean, it's so much larger than this one. It's pulling so much of the minutes in the equation out that these are just so small and they don't, like maybe it wasn't exactly collinear, but maybe we should have taken transfer patients out of the mix because maybe we care more about the people who stay at our hospital. So I think maybe taking those people out might actually improve some of these limitations that we saw.
All right. Well, thank you. Sorry to interrupt, but we just have to kind of keep the schedule going. Excellent presentation. Thank you very much for that. And our next speaker is Dr. Greg Guerra, speaking about no refusal culture for accepting interfacility transfers, has a low rate of transfer without intervention needed. So the twice twin model. All right.
Okay. All right. Well, thank you very much. And I'd like to start by thanking my co-authors, Dr. Sanjay Gupta, Dr. Jay Andon, and Dr. Jonathan Berkowitz. So regionalization of care, as well as the concentration of medical and surgical expertise at regional referral centers is expanding. And estimates suggest that the number of interfacility transfers has more than doubled in the past decade. Now, while EMTALA is intended to limit patient dumping, there really are no standards that exist to guide decision-making for interfacility transfers. And EMTALA actually requires that specialty centers accept transfers from lower-level care facilities. As such, we at our institution have instituted a no-refusal policy for interfacility transfer requests. Now, this is important. What becomes important about this is that accurate selection and triage of the interfacility transports is paramount. And referring physicians in our system are really entrusted with assigning an appropriate transfer tier. So just to give you a little bit of an understanding of what our transfer tier looks like, we have a single call system for transfer requests. This is a centralized transfer center, which I'm actually at right now, given this presentation. And when you call into the centralized transfer center, you receive an automated message and a phone tree that essentially defines these transfer tiers. So the referring physician will hear, if you have a tier 1, it's for an emergent request of a time-sensitive procedure or treatment needed. Tier 2 is an urgent request for service referring facility that they don't supply. Tier 3 is a standard transfer, and Tier 4 is just simply a consult. And transferring patients that do not require specialty consultation or selecting a transfer tier for expediency may actually constitute a quality issue. So the objective of our study was to determine the rate of transfer without needed, which we term twin, and transfer without intervention or consultant evaluation, which we term twice. And this would be under a no refusal policy for transfers that are deemed life or limb threatening, i.e. tier 1s, or the need for urgent intervention that's not available at the same facility, i.e. tier 2s. We defined twin as any transfer where an intervention, meaning a procedure of any type, was not performed or required. And we defined twice as any transfer where emergent specialist consultation was not required or needed. So the methods. This was actually a retrospective chart review of all interfacility transfers from January 1st, 2020 to November 30th, 2020, to a suburban tertiary care hospital with 75,000 ED visits annually. A detailed log of all interfacility transfers is maintained by our centralized transfer center in a system called the Incident Management System, as well as locally with our patient logistic unit. The CTC log, or the IMS system, was actually reviewed for transfer tiers, sending hospital, receiving service requested, and charts at the regional referral center were reviewed for disposition, consultations, interventions, and hospital length of stay following the transfer. Descriptive statistics. The primary outcome of interest was a twin or a twice for tier 1 or tier 2 transfers, and descriptive statistics were utilized. In addition, we performed logistic regression to identify any characteristics with significant odds ratio for a twin or a twice. And these are our results. During this time period, we actually had nearly 1,100 transfers. It was actually 1,099 transfers during the period of time. And there were, of those nearly 1,100 transfers, 361 of them were tier 1 transfers, and 476 of them were tier 2 transfers. There were 9, and the mean hospital length of stay for tier 1s were roughly 7.1 days, or mean of 7.1 days with a standard deviation of 7.2. And the hospital length of stay for tier 2s were 6.2. 51 of the tier 1 transfers expired during their hospitalization, which was roughly 14%. And for tier 2s, roughly 16% of them expired. And a few of those did actually expire within 24 hours of their transfer. There were a higher number of tier 1s that expired within 24 hours of the transfer compared to the tier 2s. Most importantly is discharge home after arrival. So one would expect that tier 1s and tier 2s should really not be discharged home from the emergency department immediately after their arrival, because technically these are sick patients that need to undergo certain procedures or specialty evaluations. And we found that 9 or 2.5% of the tier 1 patients were discharged from the ED after transfer. However, of that group, all tier 1 transfers required specialty evaluation. So there was 0 cases of twice transfer without intervention or consultant evaluation. 6 of those 9 patients who were discharged home after arrival required no intervention. And just to break those down for you, 5 of them, it was determined that it was just basically some imaging discrepancy. Typical one that you can imagine was a patient who's transferred over for a CAT scan of a head that potentially shows an intracranial hemorrhage, and then when reread by potentially a neuroradiologist, there's a disagreement, or a repeat CT, there's a disagreement on it. So that accounted for 5 of the cases. And then there was 1 trauma-related case, which was a gunshot wound to the thigh that was essentially seen, evaluated by the trauma team, and then no interventions were necessary, and the patient was able to be discharged. For tier 2 transfers, there were actually 22 patients who were discharged from the emergency department after transfer, including 2 transfers that did not require intervention or consultative evaluation. Of those 2 patients, one was actually a hand injury that the emergency department felt very comfortable in taking care of, and the second one was a cancer patient that essentially required transfer to hospice care as the main treatment. Of those 22 patients who were tier 2 patients who were discharged home after arrival, there were 13 twins, so transfers without intervention necessary, or 2.7%. 6 of them were for imaging discrepancy, like I described before. Another 2 were trauma related. 1 was pregnancy related. It was a patient that was in second trimester of pregnancy and essentially had abdominal pain and then really just needed an MRI to evaluate. And then there were 4 others. I can tell you of the 4 others, they were all urology cases. And when we did logistic regression on the twin cases, we did not identify a specific service requested or a sending hospital as being associated with increased odds of twin. Limitations to this study. Well, obviously it's a small sample size at a single hospital setting. So that's going to limit some of the results that we get. Of course, there's the concern of selection bias. So interfacility transfers are typically transferred for the specialty consultation. And so one can argue that that's exactly what they're being transferred for. So, there's not many other emergency physicians that when they are transferred in that are not going to get that specialty evaluation. But in fact, as we showed in our results, there were that occasional case that when they did arrive at the referral center, we found that really no additional immediate intervention was necessary. And the fact is that they could really just be taken care of and sent out as an outpatient for specialty consultation. And then the last limitation is that there really was no specific effort to educate the sending physicians on the differences between tier 1s and tier 2s. When you call into the system, again, you get the phone tree and the message that kind of describes them. And the CTC agents will also inquire about the need for a tier 1 or tier 2 transfer, but they certainly will not sway the sending physician or referring physician in one way or another, because of course they have the patient in front of them and know what is best. So in summary, the proportion of twin and twice was very low among sending physicians that assigned a tier 1 or tier 2 transfer. And it actually supports a culture of no refusal, where you can simply just accept these patients and have them brought on over. Thank you all for your time.
All right, thank you, Dr. Garrett. Does anybody have any questions for him about the project or the process? As a moderator, I'm supposed to always ask a question. There's an uncomfortable silence, but since I see him like 5 days a week, I don't think I need to ask him anything.
Sounds good.
Yeah, I think just a comment, which is a good point that you brought up, is as we, if you're going to develop these regional transfer systems, it seems like it works well with the auto accept in the tier 1, tier 2. But I think you brought up a good point of, the other outlying hospitals in your network that may utilize this. Is do you standardize understanding, and is there education that needs to go in, as pre-work? And it probably actually does seem like, because I'm sure if we actually dug into this deeper and looked at the different hospitals in our network, the community sites, the smaller sites with less access to consultative services, we'll probably find that there are certain sites that are utilizing this more. And as we add new hospitals into the network, we could probably see a difference. So I think that's actually a great point, something to think about if you guys start thinking about regionalizing your transfer system, within your networks.
Yeah, one of the things we're actually doing is we're going to embark upon an educational effort so that we can actually reduce the number of tier 1 transfers across the system, because they have some significant implications on the use of EMS and interfacility transports overall. So thank you.
All right. Excellent. So our next speaker, we'll get right into it, is Dr. Henna Kokar from Yale Board of Boarding, a propensity matched examination of emergency department boarding and hospital length of stay. Good. Are you able to share your screen?
We're going to find out.
Ah, look at that. All right, excellent. You have 10 minutes.
Perfect. All right. Good afternoon, everyone. My name is Hannah Kocher, and the title of my presentation, as you can see, is Board of Boarding, a propensity matched examination of emergency department boarding and hospital length of stay. I don't have any disclosures. So to give everyone some background, this work was inspired by the innumerable experiences many of us have had working within the constraints and struggles of our own EDs and the boarding we experience, as we and our patients often wait for a hospital bed to become available. ED overcrowding has been linked to poor patient outcomes, including increased inpatient mortality. And in Australia, where a lot of this work is done and the boarding is called access block there, they've noted up to 20 to 30% increases in inpatient mortality directly attributed to boarding specifically. And for many of us, boarding is only getting worse. Long gone are the days when it was thought this might be a transient trend or a new phase, but for many hospitals worldwide, boarding has become, unfortunately, the new normal. Specifically, hospital length of stay is a major outcome of interest because of the clinical, the operational, and financial harms that prolonged hospital length of stay has, including increased rates of nosocomial infections, hospital stagnancy, and greater inpatient costs to both the patient and the facility. As Dr. Ganey alluded to in her presentation, the current literature is limited and conflicted and subjected to significant selection bias within patient populations, as the patients who board are fundamentally different in their demographics and their care needs from the patients who don't board. So accordingly, we conducted a retrospective propensity matched analysis of ED hospital floor admissions to examine the associations between boarding and in-hospital length of stay involving select clinical conditions that allow for more predictable inpatient pathways. We included all floor admissions from the ED between February of 2016 and February of 2018 in a large tertiary care urban academic hospital center with an annual ED census of greater than 90K. Of note, within this time frame, there were no major quality improvement or operational initiatives that were concomitantly taking place that would influence boarding. So we conducted 7 condition-specific cohorts for matching, which you can see on the screen. They were pneumonia, UTI, fluid and electrolyte disorders, COPD and asthma, skin and subcutaneous tissue infections, heart failure, and intestinal obstruction ileus. Each of these was defined by the ED provider's specified admitting diagnosis, according to their HRQ ICD-10 coding classification. Patients were then matched based on their demographics, their emergency severity index, their telemetry needs, their inpatient versus observation status, their insurance type, and their comorbidity index. Our outcomes of interest were inpatient length of stay and hospital length of stay, which are differentiated by the patient's time spent in the emergency department. This graphic helps to delineate how we defined our outcomes, namely inpatient length of stay as the time from ED departure to hospital departure, and hospital length of stay as the time from ED arrival to hospital departure. We defined boarding as the interval from the time of placement of an admin order to the time of the patient's departure from the ED as being greater than 4 hours. The primary objective of the study was to determine if whether or not ED boarding is associated with prolonged lengths of stay, directly comparing admitted patients who did and did not board within the ED. We hypothesized that in a matched analysis, boarded patients would experience both longer inpatient and hospital lengths of stay than their non-boarded counterparts within each clinical cohort. Our results are graphically displayed here, with the figure on the left showing our inpatient length of stay data and the figure on the right showing hospital length of stay data. We had a total of 9,222 patient encounters, including across the 7 diagnostic cohorts. As you can see, the overall inpatient length of stay analysis did not show a length of stay difference that was clinically significant associated with boarding, with the sole exception being intestinal obstruction ileus. When looking at hospital length of stay data, however, most of the clinical conditions exhibited our hypothesized outcome that boarding was associated with prolonged lengths of stay. Specifically, asthma COPD and bronchiectasis patients who boarded had a 12% higher hospital length of stay, fluid and electrolyte disorders 19%, UTI 12%, skin and subcutaneous tissue infection 17%, and pneumonia 11% compared to their counterparts who did not board. So after rigorous patient matching, we found no broad association between ED boarding and inpatient length of stay. However, there was a consistent relationship between ED boarding and total hospital length of stay. This suggests that patients who board in the ED may be subjected to a no man's land of care, with the initiation of inpatient care pathways being delayed to the time of ED departure. Integration of inpatient care into boarding time would likely result in reduced lengths of stay, improvement in hospital efficiency, and reductions in the safety risks associated with the limited accountability that occurs during boarding. I just wanted to acknowledge the wonderful people on this slide who made the study what it is, and yeah, sincere thank you. And I'll take any questions, or if offline, my email is included on the slide. Feel free to reach out.
Yeah, thank you very much for the very interesting presentation. I mean, it hits a topic that hits us all. Does anyone have any questions for Dr. Kochar? All right, so I have a question. So, so with your determination, you use 4 hours as a cutoff that boarding starts after 4 hours.
Mm-hmm.
How is that 4 hour time frame kind of derived?
Sure, great question. So we did notice similar standards in the literature that provided a starting point for the definition that we used. And as well at our hospital at the time, not that this influenced decision-making, but it happened to correlate nicely, because at the time we were using 4 hours as a cutoff for when there was an assumption that an inpatient care team had taken over, and that the ED was a resource there for any emergency or any immediate care that needed to take place, but that technically it was understood that responsibility shift had occurred.
Okay, yeah, I mean, I think that's excellent. And then just one follow-up in your shop. So if inpatient orders are placed and the patient is boarding in the ED, is it an expectation that ED nurses pick up those inpatient orders, or do you have like a set of, I guess, boarding nurses that pick up orders? Is there any process like that?
The processes have undergone a significant amount of permutations since this study was done. At the time, I believe that it was the expectation of ED nursing to carry out inpatient orders within certain levels of expectations. So as I'm sure we can attest to multiple different EDs, especially academic EDs, nursing is usually stretched pretty thin between handling incoming emergent patients versus patients who are quote unquote on autopilot. But that autopilot mode doesn't happen unless nurses conduct the orders that they're supposed to do. So the general understanding was that new ED patients were to take priority, however, orders were to be respected.
Yeah, I mean, I think it dives into the perpetual discussion of what our role definition of an ED nurse is, and it's very difficult to take care of acute and new patients and expect it to handle the responsibilities of inpatient type nursing simultaneously. With that,
absolutely, and we did have the development of a boarding unit after the time frame of this study, where there were inpatient nurses who were assigned to taking care of patients who were selected for this boarding unit. But a lot of the demographic needs and other, factors that were mentioned in the study that delineate stable boarding patients from patients who could board but under ED care factored into that. So it was a little unspoken, but we all, underwent our own individual thought process of, is this patient stable to go to a boarding unit versus do we want to keep them in our unit rather than send them even though they are boarding by definition.
Gotcha. yeah, I mean, these are, I think, discussions that are important for us to have and to tease out what's best for patients. So wonderful. Thank you very much.
Thank you.
I think next presenter will be Dr. Bright, and I'm going to be sharing the slides. Okay. And so, Dr. Bright, whenever you're ready, you can start and just, I guess just say next slide or something similar when you want the next slide up.
Okay. So I'm Erin Bright. I'm a resident from Yale New Haven Hospital, and this is my presentation on the abstract, Emergency Physician Performance Metrics, Mixed Messaging or Balancing Forces. So special thanks to my co-authors and then Dr. Gupta for helping me with the slides as well. Go on to the next slide. And are you guys seeing Dr. Gupta go along the slides?
You're still on slide 1 right now.
Oh, you are? Okay. How about now?
Sure,
Disclosure?
email.
I still see slide 1.
Okay. Oh, you know what? Here we go. Sorry, guys. I'm just going to reshare. I did download it, so I'm going to stop share and then share again.
I think we've learned that my PowerPoint is the issue.
No. This should work. Do you guys see this? Is that better?
I don't think you're sharing.
I don't see anything at the moment.
Okay, and I'm revealing my age with my inability to use Zoom, so.
What are you trying to do?
Oh no, I'm just trying to share my screen to make sure I'm not sharing anything right now, right?
Correct.
Correct.
No.
Yeah, no, it's just my Zoom actually, which is now not, it's frozen a little bit. Give me 1 second. Okay,
We're there.
are we up?
Mhm.
We're there, okay. Let me just get that onto, there we go.
Okay, so we'll go to the next slide, and I have no disclosures. So physicians are evaluated based on enumerable throughput, resource utilization, safety, and billing metrics. Reporting performance metrics is costly and can lead to mixed messaging for incentives. Identifying patterns in a larger number of ED metrics could improve how quality measures are reported to physicians. Go to the next slide. Previous work has found that patterns exist among commonly reported ED metrics, and some ED metrics, such as physician treatment times, are more reliable over time than others. But there's a lack of variety in the metrics included in previous publications on this topic. Go to the next slide. We sought to characterize the relationship between several common emergency physician metrics across a range of clinical processes and outcomes. So this study was a retrospective cohort analysis of resource utilization, throughput, and safety metrics for EM physicians across 7 EDs within our large hospital system. Data was included over a 2-year period and queried from an electronic health record-based physician dashboard. Physicians who had less than 100 patient encounters during that time period or who had missing data were removed from analysis. And the performance metrics were analyzed using a Pearson correlation analysis. This table outlines the performance metrics included in our analysis. Bolded are the metrics that are less commonly reported, have varying definitions based on institution, or were new to our institution at the time of the analysis. To highlight a few, short stay admission rate was defined as % of total admissions discharged within 24 hours. % attending only cases was defined as % ED visits with no advanced practice provider or resident assigned. Escalation rate was defined as a % admissions transferred to a step-down unit or an ICU within 24 hours of admission. And 72-hour return rate was defined as % of patients discharged who returned within 72 hours and required admission. Our analysis included 237 EM physicians. Significant positive correlations were found between CT utilization rate and admission rate, and then strong positive correlations were found between the time throughput metrics. So as a reminder, this is looking at physicians at the individual level and their CT utilization rate and if it's correlated with the higher admission rate. And we considered a correlation to be strong if it was greater than 0.4, if the R value was greater than 0.4 or less than negative 0.4. And then a significant if it had a corresponding p-value that was less than 0.05. So significant negative correlations were found between CT utilization rate and short stay admission rate, 72-hour return rate and short stay admission rate, patients per hour and % attending only cases, and ED visits with critical care time billed and % attending only cases. This is a scatter plot depicting CT utilization rate on the x-axis and admission rate on the y-axis. Each point on the scatter plot depicts a single EM attending physician. There was a strong positive correlation between a higher CT utilization rate and a higher admission rate. This graph depicts the 3-time throughput metrics that we looked at in our analysis. So room to doctor time is represented by 3 colors, purple representing physicians with the fastest room to doctor time, and yellow representing physicians with the longest room to doctor time. Room to admit time is represented on the x-axis and room to discharge time on the y-axis. So there were strong positive correlations between attending physicians who had a faster room to doctor time, were also more likely to have a faster room to admit time and room to discharge time. This graph depicts 72-hour return rate and short stay admission rate. So overall, a higher short stay admission rate was correlated with a lower 72-hour return rate, but this was a weak negative correlation. And then additionally, there were some physicians that had both a low 72-hour return rate and a low short stay admission rate. We did not find significant correlations between patients per hour and 72-hour return rate or patients per hour and escalation rate. Limitations of the study, we did not adjust for shift type worked or patient acuity, and we assumed that physicians worked a range of shift types and saw a variety of patient acuities. Additionally, we did not adjust for providers who worked more shifts with advanced practice providers or with residents. So our conclusions, some metrics have negative correlations and are likely to frustrate physicians seeking to perform highly across all metrics. This could impede the success of concurrent quality improvement interventions that seek discordant outcomes. So an example of this would be expecting attending physicians to have a high patients per hour and a high attending only cases, when in reality, when we looked at all the physicians in our system, those two things are negatively correlated. There are strong positive correlations across the time throughput metrics, and it's redundant to report multiple time metrics to physicians. And then higher CT utilization rate is correlated with a higher admission rate, and this is consistent with previous publications. A couple more conclusions. So a higher short stay admission rate is correlated with a lower 72-hour return rate, but this correlation is weak, and some physicians did have both a low 72-hour return rate and a low short stay admission rate. And then lastly, a higher number of patients per hour was not significantly correlated with a higher 72-hour return rate or a higher escalation rate. So for future work can identify whether relationships among ED throughput, resource utilization, and safety metrics vary based on academic versus non-academic EDs. In this analysis, we include this all in one cohort. Additionally, which metrics, when presented to physicians, can have the most impact on clinical care and patient-oriented outcomes? And lastly, how can feedback be delivered to physicians to optimize satisfaction with performance feedback and ultimately lead to lasting behavior change?
All right, excellent. Does anyone have any questions for Dr. Bright?
Hi, Dr. Bright, this is Greg Guerra.
Hello.
So excellent job considering all of the technological issues that you had.
Worked out.
We have all been there this year. Anyway, I just had a couple of questions. I mean, when you say short stay admission, are you talking about patients who are admitted and then discharged from the hospital within 24 hours, or are these patients that are basically being placed on an observation status?
No, so these are patients that were full admissions that were discharged within 24 hours. So the reason why we included this is we started sending this information to attending physicians so that they had insight into, I admitted this person and they were discharged 12 hours later. Could there have been something that we could have done in the ED to prevent that admission? Because they didn't require that long of a hospital stay.
But yet those patients were actually had a higher rate of return within 72 hours of their premature discharge from the hospital.
Actually, no. So the attending physicians who had a higher rate of admitting patients and then later having them discharged, that individual attending also had a lower 72-hour return rate. So not necessarily the same patient encounter, but that physician might be avoiding 72-hour returns by admitting patients, even if it's only for a short period of time.
Gotcha. And then the other finding with the CTs and CT utilization and admission kind of makes sense. It goes along with everything else, right? Physicians who are potentially ordering more tests, high test utilizers probably also are high admission utilizers as well.
Exactly.
Excellent work.
Thank you.
Yeah, great work, great project. Thank you. And our final presentation of the day will be by Cole Davis, the effects of COVID-19 pandemic on ED volume and acuity. And this presentation was sponsored by the AAA-EM.
All right, let me get it set up. Everybody hear me okay?
Yep.
All right, let me share that and I will start this here. All right. So like Dr. Gupta said, my name's Cole Davis. I'm a graduating medical student at Emory University School of Medicine, and I'll be starting residency at the University of Cincinnati here in about 6 weeks. And my presentation today is the effects of the COVID-19 pandemic on emergency department volume and acuity, as well as the frequency of selected high acuity conditions. So we have no financial conflicts of interest to disclose for this presentation. A bit of background, as I'm sure you're all very aware, the COVID-19 pandemic pretty much devastated the globe in 2020. Throughout the world, rising coronavirus infection and mortality rates forced governments to implement massive quarantines and mask mandates. Hospitalizations and mortality from the virus itself skyrocketed in the early spring, and hospitals really found themselves unable to keep up with that influx of patients. In late April, over 150 US hospitals had exceeded their ICU capacity, with 2,300 counties representing over 300 million Americans actually predicted to exceed their ICU capacity by early June. The emergency department, however, really didn't follow this trend. Throughout the world, emergency department census dropped significantly at the start of the pandemic. In England, a 25% decrease in ED volume was noted the week after the nationwide stay-at-home order started. In the US, the CDC, as actually can be seen from this graph, the CDC noted a 42% decrease in ED volume in March and April of 2020 when compared with the same period of 2019. Presentations for high acuity conditions like stroke and STEMI also decreased at the start of the pandemic. Multicenter trial completed here in 4 countries actually noted a 17.6 and 39.2% decrease respectively in March and April for STEMI volume compared to those same months in 2019. Multiple hypotheses for this, such as poor public health messaging advising patients to come to the ED, or simply the fear of contracting COVID while at the hospital, were floated as potential reasons why patients were avoiding the emergency department. So for our study, our goal was to analyze the impact of the early COVID-19 pandemic on emergency department volume, average acuity, and then stroke and STEMI volume at a public safety net hospital to potentially inform future public health messaging. A bit about our methods. It was a retrospective review of all adult patients, which was an N value of just under 107,000, presenting to the Grady Memorial Hospital Emergency Department from January 1st to May 31st of both 2019 and 2020. A little bit of background about Grady. It's an urban tertiary care hospital. It's also the safety net hospital for the city of Atlanta, serving a very much underserved patient population for whom the emergency department is often the only medical access they have. We used a pre and post comparison using March 11th as the cutoff date. March 11th was the date that the WHO declared COVID-19 a global pandemic. And then acuity was scored via the Emergency Severity Index of the ESI system, and stroke and STEMI data was captured via relevant ICD-10 diagnostic codes. So when we look at emergency department volume overall, we found a 23% decrease in patient volume after the March 11th pandemic start date compared to that same period in 2019. ED volume actually increased slightly from January to May in 2019, as can be seen with our rate ratio of about 1.03, but decreased in 2020 with a rate ratio of 0.77. The interaction that we found actually with the March 11th pandemic declaration date, indicating here that the volume change from January to March and March to May in 2019 and 2020 was very different when you compare the two, as can be seen pretty obviously from the blue trend line of the graph dipping significantly after that March 11th date. Of note, Atlanta and DeKalb County, where Grady is located, enacted a stay-at-home order on March 23rd, and a statewide stay-at-home order was enacted on April 2nd. Interestingly, as you can see here, the volume dipped significantly before the stay-at-home order for the city was enacted, and actually began to increase after the statewide stay-at-home order was enacted. So it may, and we can't obviously confirm this, but it may call into question the efficacy of stay-at-home orders in preventing ED visits specifically. The 23% reduction in patient volume that we noted after the start of the pandemic was accompanied by a rise in average patient acuity level. Since we utilized the ESI at triage with a score of 1, a lower score indicating a more emergent patient, and a score of 5, a higher score indicating a less emergent patient. So a lower score here indicates that on average, patients were quote unquote sicker when presenting to the ED. Acuity increased in both 2019 and 2020, but it was a much more significant increase in 2020, as again can be seen by the notable dip in our blue trend line on the graph here. All right, some high acuity conditions data. When looking at stroke volume, the percentage of patients who were given a diagnosis of stroke, ischemic or hemorrhagic, was increased in January, the whole study period, January through May 2020, compared to 2019. However, we found no significant interaction with that March 11th cutoff date, indicating that there was no significant difference January to March versus March to May between 2019 and 2020 when looking at stroke. When we study STEMI, it can be seen that STEMIs were actually more frequent in 2019 than 2020 overall. And again, we found no significant interaction in the pre and post-COVID period. So that March 11th cutoff date, we found no significant interaction. It may be worthwhile to note, however, that in 2020, you can notice towards the beginning of May that STEMI volume actually overtook that of 2019. And that may be due to the increased thrombosis risk associated with COVID and the extremely high COVID burden we saw in Atlanta and in Georgia, potentially increasing the incidence of strokes and STEMIs, and therefore may have contributed to that overtaking of 2019's data. So a bit about some conclusions for us here. As you can see, this is the CDC's graph from the Morbidity and Mortality Weekly Report that noted the 42% decrease compared to 2019. And our data was very similar. We saw a 23% decrease after the March 11th cutoff date. This finding has been repeated multiple times in multiple studies. As mentioned, there were many, many studies that found that ED volume decreased at the start of the pandemic. When we look at acuity, again, many hospitals found that their patients were coming in on average sicker, and we determined the same, as our average acuity scores dropped about 0.15 throughout the study period when you look at the cutoff date of March 11th. We can't say without interviewing the patients whether they were delaying care due to fear of COVID and allowing their conditions to progress, but it does offer potential avenues for future studies if we can contact patients. And then when we look at these high acuity conditions, as mentioned previously, multiple studies noted a decrease in high acuity condition presentations such as stroke and heart attack. early in the pandemic, with the CDC noting a 20% decrease in STEMI admissions, or 23%, excuse me, and a 20% decrease in stroke admissions after March 13th of 2020. We, however, had no significant decrease in these conditions. We hypothesized that these really unexpected results may have been due to the shuttling of STEMI and stroke patients to Grady, as it's rather the premier care center for these conditions in Georgia. Again, the increased risk of thrombosis due to COVID and the high COVID burden causing increased incidence, or hopefully successful public health messaging in Atlanta advising patients not to avoid the ED if they notice symptoms of these conditions. We did a bit of extra work that's not included in the abstract itself, but is included in a further study on cardiac arrest and trauma data. We found no significant interaction with cardiac arrest data and really not a significant increase in 2020 compared to 2019. Trauma, however, we actually noted a 28% increase overall in the amount of trauma that we saw in 2020 versus 2019, but no significant interaction with that March 11th cutoff date, indicating that the pre and post COVID period did not see a significant difference from 2020 versus 2019, which again is an interesting result, as there was a single study out of Philadelphia that indicated a greater percentage of firearm and domestic violence trauma after the start of the pandemic, which really bucks the trend, as we would expect trauma to go down with lower interpersonal contact, patients not driving to work, et cetera. So this was an interesting study that we noted in the end. I would like to thank all the co-authors on the paper who served as my mentors for this, Dr. Irfan Hussain, Dr. Timothy Moran, Dr. Haney Atala, and Dr. Daniel Wu, and I'd be happy to take any questions that y'all may have.
Yeah, any questions for Dr. Davis? I will ask a question. I don't know if you have this data. So one of the findings that we had in New York City, kind of with our COVID experience, was an increase in out-of-hospital cardiac arrests by about threefold, related to the pandemic. And the concern was, people were afraid to come to the hospital. So, there might affect STEMI numbers, because we presume that most of those cardiac arrests are due to MIs. Did you have that same sort of experience in the catchment area for Grady? I don't know. I mean, it's a very specific question. Do you know if your rates of out-of-hospital cardiac arrests actually went up during your acute COVID era period, or even soon thereafter?
That's a great question. I do not know if the out-of-hospital cardiac arrest numbers, out-of-hospital STEMI numbers went up. I know that the ones that presented, and what we saw at least, we really didn't see significant increases, but I'm not quite sure if the out-of-hospital numbers that didn't make it to the ED, if we had an increase there.
Yeah, because that's always a thought, that if you look at your local prevalence rate, and then if people having STEMIs just were not coming in because they were too afraid of COVID, and they were passing due to MIs at home, does that have an effect? But again, very specific question. It was something that we have really robust data with FIDNY, New York City EMS. So that's one of the kind of our local findings. So didn't know if that translated to other municipalities as well. All right. Well, excellent. Everyone, thank you very much. This was an excellent operations session. I certainly got some great ideas from you guys, and there are a lot of really smart people out there. So glad you guys are all doing this. All right. All right. Great. Thank you all.